We have the honor of having some guests from the Iberoamericana University in Tijuana. So we have the university president here. They're both physicians, but Dr. Florentino Badial, epidemiologist who trained in Guadalajara, did much of his training there. But also was a Jesuit, so he's had multiple professions, and we were honored to have him here. We also have Victor Caballeros, who is going to be the dean of the School of Medicine for the Tijuana Ibero. It will be the first Jesuit medical school in Mexico. And so we're honored to be developing a relationship with them and their school. And we feel like we have lots of areas where we're overlapped. They're both experts in epidemiology. So we'll first hear from Dr. Victor Caballeros, who will talk to us about the epidemiologic panorama in Mexico. And then we'll hear from Dr. Badial, who will talk to us about HIV prevention in Mexico. They're experts in their field, and I'm looking forward to hearing from both of them. So, Dr. Caballeros.
Thank you very much, Randy. I don't speak English. I'm sorry. Florentino me ayudará a poder expresarme. No sé quiénes hablan español. Todos. Es un honor para nosotros estar aquí. Muchas gracias. Estamos en un proyecto de hermanar, conjuntar ambas instituciones. Es muy valioso lo que estamos haciendo y gracias, Randy, y gracias a todo tu equipo por el apoyo.
Okay, okay. So he asked how many of you speak Spanish, but we only saw one hand. So we're gonna keep on with this translation system. We're very, Dr. Caballero, well, I'll be speaking, translating what he's saying. We're very happy to be here and very glad to be sharing with you this moment and this experience. Yes.
Vamos a imaginar que
This is going to be a very brief review on the panorama in Mexico. We're going to kind of have a drone or hawk-eye view of what's going on in Mexico. Gracias. Yeah. Thanks.
Gracias. No, se escucha mejor.
I cannot translate that.
Topics, o sea, una revisión general de lo que es México, para quien no lo conozca, la que llamamos nosotros transición epidemiológica, temas demográficos de México, la morbilidad y la mortalidad y enfermedades emergentes. De eso hablaremos rápidamente.
Translation is on the screen.
Okay. Somos un país que tiene 130 millones de habitantes aproximadamente. Nuestro territorio, casi 2 millones, 2 millions kilómetros, ¿no? 758,000 millas. Así es como lo traducimos. Tenemos lo doble de densidad poblacional que Estados Unidos. O sea, menos población, pero menos población, menos territorio, pero la doble de densidad que Estados Unidos.
Population density is twice the one we have in the United States.
Nuestra expectativa de vida es 75 años. 75 years. Pero estamos, después de la pandemia, disminuimos 3 años. Ahora, ¿sí? La OCDE, la Organización para el Desarrollo Económico, recomienda que tengamos 80 años de vida como promedio. ¿Sí?
We came 3 years back when it comes to life expectancy due to the pandemic in Mexico. And the goal, according to WHO, is to reach the 80 years life expectancy.
Hablamos en México de que tenemos tres Méxicos diferentes. El México del Norte, un México industrial, muy productivo. El México del Centro, que es comercial, turístico, comercial. Y el México del Sur, muy pobre. Económicamente, el más pobre de los tres. Más riqueza arriba, menos riqueza en medio y muy pobreza al sur, más o menos.
So there's three different realities in Mexico in general terms. And northern Mexico is more industrial and richer than the other regions. Central Mexico, well, it has very large cities and very touristic, and there's commerce and a lot of people live there. And then the south, Mexico, southwest, southeast Mexico is very poor. The population is very poor. And so three different realities.
Esta zona se salva por el turismo. Cancún.
Except for this, the peninsula, the Yucatan Peninsula, that there's a lot of tourism, like Cancun, USA. I added that.
Oh, spring break. Pero en salud tenemos 7 regiones distintas, cada una con una morbilidad muy particular. Yo quiero destacar nuestra frontera, que es, compartimos Estados Unidos y México lo mismo en la franja fronteriza. Y voy a describir eso que compartimos, que afecta a todo el país, pero que particularmente se ve en la frontera.
Among the 7 epidemiological regions in Mexico, I'm going to focus on the northern epidemiological region because of all the health realities we share with the United States. So this is where the focus will be.
El panorama de México. Transición epidemiológica. No sé cómo se...
Transition.
En los últimos 30 años hemos visto una modificación en la epidemiología de México, muy marcada. Comenzó hace 50 años, pero en los últimos 30 años la epidemiología en México cambió.
There's been a switch, a radical switch among diseases in Mexico for the last 50 years, but especially during the last 30 years.
Desde los años 70, pero particularmente en los 90, teníamos la gente muere y se enferma de enfermedades infecciosas, respiratory disease and gastroenteritis. Esa es la principal causa. Ha habido un proceso de mejora social, urbanismo, un programa muy intenso de vacunación en México, muy exitoso, que disminuyó la enfermedad infecciosa. Pero ahora experimentamos una explosión de enfermedad crónica, muy, muy aparatosa.
Besides what you can read, Dr. Caballero said that we've had a very successful vaccination program in Mexico.
Un ejemplo, COVID. Todos lo vivimos. Este es un reporte de México. Nosotros hemos tenido 5 olas de COVID. Sigue el COVID aún. Pero no hemos vacunado eficientemente. Y tuvimos una muy alta mortalidad en México. Aquí dice 380,000, estimamos 800,000 muertes en México. Y somos el país donde murieron más médicos y enfermeras del mundo, México. Y hoy tenemos todavía un problema por secuelas. No tenemos una estrategia para tratar las secuelas de COVID.
We've had a very difficult time during the COVID pandemic. We had 5 big waves. In this, the vaccination program wasn't that successful as other vaccination programs. And this is the official numbers, 300 and almost 50 thousand deaths during the pandemic. But some experts estimate that real numbers could go up to 800,000 deaths in the country. And this is the #1 country when it comes to mortality among healthcare providers, doctors, nurses, etc. So, and it's still a challenge in Mexico due to long COVID and sequelae that come after COVID. And we do not have a program for treating these long COVIDs and sequelae.
De mi generación de estudiantes de medicina murieron 11 personas.
Only Dr. Caballeros from, how do you call that? The group, the generation, thank you. Among his generation, 11 physicians lost their lives. Only his generation.
Y hoy México vive en la coyuntura de tener una elevación de enfermedad infecciosa y un incremento de enfermedad crónica. Estamos compartiendo, coexistiendo ambas enfermedades, lo cual hace más complicado el manejo epidemiológico.
In this time, in actual times, we have this convergence of infectious diseases and chronic diseases.
Esta es la principal causa de muerte hoy en nuestro país, del 20 para acá, ¿no? Aquí hay un dato. 2.5 millones de casos, más 10.4 millones de enfermedad respiratoria no diagnosticada como COVID, pero que creemos que fue COVID.
De los 10.4?
Sí.
Okay, among those 10.4 known cases, acute respiratory infections, non-specified, but we think many of those were actually COVID.
Y destacar que ahora, después de que desapareció COVID, hoy tenemos dos problemas que son los más importantes en México: la hipertensión arterial y el sobrepeso y la obesidad.
After COVID, high blood pressure and obesity have jumped up among the main morbidity causes in Mexico.
Compartimos México y Estados Unidos lo mismo, realmente por la consistencia.
We share this problems with the U.S. population.
Y sabemos que los indicadores de morbilidad y mortalidad tienen que marcar el rumbo de las acciones. Eso es lo que nos tiene que mover a tomar decisiones en salud, porque hoy la enfermedad crónica en México y en Estados Unidos está llevando a mucha gente a morir.
We have to take decisions based on epidemiological data, and as you are very well aware of, we share with the United States the fact that chronic diseases are the main causes of morbidity and mortality, as well in Mexico.
¿Alguien de ustedes sabe cuánto se invierte en los Estados Unidos del Producto Interno Bruto en salud?
Does someone in the room know the percentage of expenditure in government for health when it comes to the, what's the PIB, el Producto Interno Bruto, GDP, thank you. The GDP, the percentage that is spent in health services in the States. ¿Un tercio del Producto Interno Bruto?
No, quiero que si alguien tiene datos de Estados Unidos, yo encontré que más o menos entre el 7.5 está invirtiendo Estados Unidos en salud, pero la inversión es privada, no pública. En México la inversión pública es del 5.4 del Producto Interno Bruto. La pública, solo pública. La Organización para la Cooperación y el Desarrollo Económico en el mundo recomienda 8% de inversión para mantener un pueblo saludable, como en Europa.
So according to OCDE, the percentage to be spent in health in a country, in order to have a good health services, it's 8% of the GDP. In the United States, what Dr. Caballero found was it's around 7.5%, but it's mostly private investment or expenditure. In Mexico, it goes more like 5%. It's mostly public.
De esto estamos muriendo hoy en México, ¿sí? Estas son las principales causas de muerte. Un dato: la insuficiencia renal es consecuencia principalmente de la diabetes y está generando un costo muy alto por todos los procedimientos que se requieren precisamente para mantener al cuerpo humano estable cuando le falla el riñón.
Among these 10 causes of mortality, you will see that kidney failure is mostly a consequence of diabetes mellitus, and it's a very expensive disease to treat in Mexico.
Sí. Solo un dato lo voy a dejar: la diferencia entre mujer y hombre. Es importante reconocer que hay diferencias un poco en esto. Aquí tenemos enfermedades cerebrovasculares, principalmente en mujeres. Este accidente que estamos ligando ahora al uso de hormonoterapia está ligado a eso, ¿no? Más bien, pero estas son las causas principales de muerte, divididas en hombre y mujer. No me detengo por el día.
Among the difference you can see between women and men, he underlines cerebrovascular diseases that are sometimes associated with the use of hormone therapy in women.
Solo destaco que esto no debería estar aquí.
Homosexuality there. So, and it's a reality in Mexico.
Sí. La transición demográfica, la población, a partir de los años 70, ninguno aquí había nacido.
And in the 1970s, most people here were not born. That's a guess.
México inició un programa muy intenso de reducción poblacional. Pasamos del 3.6 de natalidad al 1.8 hoy.
So from the 1970s till now, there's been a decrease in population. What's the name in English? La explosión demográfica, demographic growth. We were in the rate was over 3.6
babies.
over 1,000 inhabitants, and it came back down to 1.8 right now.
Y hoy tenemos un incremento notable de esperanza de vida. Vivimos más. Y esto está llevando a
Have a longer
modificar
life expectancy.
nuestra pirámide poblacional. Es decir, en México llamamos bono demográfico. No sé si aquí se llama igual.
Do you are familiar with the idea of demographic bonus? So this is the concept we use in Mexico, and there's been a transition that the pyramid is being inverted so that there's less younger people and more older people.
El bono demográfico son ustedes, los jóvenes. Son los que con su trabajo mantienen un país y mantienen a quienes ya no, bueno, yo todavía, pero ya pronto a lo mejor no tengo que trabajar.
The demographic bonus is people who are economically active and they have to support the country, and the people who are not working anymore, they're retired.
Y esto hoy nos está llevando a un riesgo. Este bono, este grupo de jóvenes se ha reducido. ¿Y cómo vamos a mantener a una población? Existe la pensión.
You have some kind of pension, yeah, retirement.
La pensión se paga con el trabajo de todos los jóvenes. Eso tenemos ya un problema muy importante en el país, porque ya no tenemos dinero para pagar.
So this is a big problem in Mexico because the people in the demographic or economically active population, There's not enough money to support all the pension, the retirement of so many people who are retired.
Y una población adulta con diabetes es complicadísimo mantener.
And it's not only the pensions, it's also health issues such as diabetes, which is can be very expensive.
En el 2009, en nuestro país, tuvimos un enorme brote de dengue. Do you know dengue?
Yes.
Brotó por todo el país. No teníamos ese brote y llegó por todos lados. Y esto, bueno, todavía hoy tenemos un problema serio. No tenemos todo el control de dengue.
In 2009, we had this peak on dengue cases, and we still do have a lot of.
Y en el 2023, el año pasado, tuvimos y tenemos un brote de rickettsiosis en el noroeste, Sonora, Baja California, Chihuahua. Tenemos rickettsia.
In the northwestern region of Mexico since 2023, we've had a peak in rickettsiosis cases.
Y voy a centrarme finalmente en este tema que es en donde tenemos que invertir en México todo. No para curar la diabetes, sino para evitar que haya personas con diabetes.
So I'm going to focus lastly in this diabetes and obesity epidemic, because that's where we have to put all our efforts, not only in treating them, but in preventing them.
Porque el problema es este. La gente que no sabe que tiene diabetes, ese es el problema. Y tenemos que estar trabajando continuamente para que haya interés en el autocuidado.
We have a high number of people who have diabetes and do not know it. So we have to do a lot of work in self-consciousness and self-care.
Entonces, la diabetes es la epidemia más importante en México hoy.
Nowadays, this is the most important epidemic we have in Mexico.
Hemos tenido un notable incremento, se ha duplicado la tasa de diabetes en nuestro país. Ahí es el inicio. Hoy, 7 de cada 10 mexicanos tenemos sobrepeso. Ese es un tema muy importante que lo tengo por regiones, pero lo que yo decía, el costo de atender la enfermedad es $3 millones al año nos cuesta mantener 60 millones de pesos solamente el programa que tiene público de diabetes, pero no todo el privado.
¿Es el costo del programa total?
Sí,
Hoy. Okay, that's the cost of diabetes prevention?
Sí. No, es la curación.
Okay, that's the cost of the diabetes program in Mexico.
Es lo que se está gastando, pero
the actual spending in Mexico.
No tenemos tratamiento para la enfermedad renal, aquí sale fuera.
It does not include kidney disease.
Entonces, hoy tenemos un debate porque tenemos que invertir más, pero hay quien dice que el problema no es del gobierno, el problema es de la gente. Ahí tenemos un enorme debate. ¿Quién tiene cómo resolverlo? ¿Si con educación o con mayor inversión? Y creemos de que hay que trabajar las dos cosas.
So there's a debate on who's responsible and who has to take care of this problem, if it's people themselves through taking care of themselves, or if there has to be investment in education and care. And so Dr. Caballero says it has to be both.
Cuando yo era niño, todo lo comprábamos en los mercados. Yo iba con mi mamá a cargar las bolsas con comida. Era habitual, ¿no? Pero
when he was young, he used to go to the market with his mom and carry the bags for her.
Hoy ya nadie necesitamos ir al mercado.
No one needs to go to market anymore.
Y es un problema un simple ejemplo de que todo lo hacemos sin movimiento, sin movernos. Ese es el problema, seguramente aquí, y probablemente allá también.
It is a growing problem that you don't actually need to move to get what you need. You don't need to walk.
Y además, la asociación en los niños, diversión, juego, fiesta, es igual a comida, fast food.
For children, the message now is that having fun is always eating something and eating fast food or junk food. Most of the time.
Recientemente yo trabajé con un grupo con el Instituto de Salud Pública en México y encontramos que los niños entre 6 y 12 años, cuando van a la mitad de la escuela, comienza a ya no haber correlación en su peso y su talla. Comienzan a tener mucho más peso en relación con lo que debieran tener. Cuando tienen, estamos hablando 8 años, más o menos, de 8 en adelante.
Well, this is not journalist. This is Dr. Caballero used to be the Secretary of State for the state of Morelos in southern Mexico, where the National Institute of Public Health is. So the rest is translation. What he was saying is that when he worked there in Morelos, in a study done with the National Public Health Institute, they found that in the what would be the third year in Mexico of elementary school, 9 to 10 years old children, the correlation between height and weight begins to split, you know, to lose the healthy relationship.
Y también encontramos otro dato importante. Hay sobrepeso y obesidad en niños recién nacidos. Hoy creemos que está la hipótesis que es por la ausencia de lactancia materna. Es un tema que también abandonamos ya en México. Antes se impulsaba mucho, ya no.
In Mexico, we found that there's overweight and obesity even among very young children, those who are less than 1 year old. And the reason for this is most likely related to the non-use of maternal, help me here.
Prenatal care?
Lactation. Thank you very much.
Oh,
Yes.
lactation, feeding them.
Yes, because it's not
Feed
using
baby.
natural feeding, we're using formula. So this is behind many causes or many cases of obesity and overweight in very young children.
Y queremos impulsar un programa muy simple, muy sencillo, que es observación, detección de la resistencia a la insulina que podemos observar en niños escolares. Queremos impulsar ese programa para que los maestros de la escuela puedan darse cuenta qué niño requiere atención médica.
It's important. Yeah, it's important to train teachers in elementary schools to find acanthosis nigricans so that they can send these children to medical care in time.
Cierro con esto. Hoy tenemos un gran problema en México, muy grave, sí, que es la violencia. Es algo que sabemos que se va a acabar, tenemos esa confianza, pero hoy tenemos que resolverlo todos los mexicanos, sobre todo aquí, Sinaloa y Guerrero, están incendiados con violencia, todo el país, pero ese es un tema que impacta notablemente en la salud, por todo lo que significa no solo la muerte, sino la incapacidad y la salud mental. Es un tema que también epidemiológicamente tiene gran impacto, los problemas de salud mental por violencia.
We have a very grave or very severe epidemic in Mexico related to violence. Violence is an epidemic itself, especially in certain states. And it's not only about mortality due to homicides, it's also long-term disability and also mental health issues and how it affects the rest of the family.
Tenemos estos 4 retos que yo les llamo sueños. 1, pues gastar más, invertir más en salud. 2, un programa de educación desde los niños para que se sepan cuidar en lo que comen, en lo que viven y tengan mejor salud, un mejor acceso a los servicios de salud y, por supuesto, formación médica, que es lo que estamos haciendo juntos, ¿sí? Formar médicos y médicas o profesionales de la salud con un compromiso social para cuidar la salud de todos.
So besides what you can read, education in healthcare has to begin since the very early ages with children. And then in the fourth bullet, the training of health professional has to be or needs to be with a social vision. To visit us and we are building a partnership that Randy has said so that we can become part of an academic program or immersion program or something similar, and also our students, and not only medicine students, also nursing. We have nursing, we have nutrition, and we have psychology when it comes to health care programs. So this is the university. We are a Jesuit university, as is great. And as Randy has said, we will soon have medicine. And I apologize because some of the slides are in Spanish, so I will translate them. So, as I was saying, I will share with you some of the experience we have in the Condesa clinics, specialized clinic, Mexico City, and some of the data are very impressive. The HIV diagnosis program in the clinic went from offering 3,400 tests a year up to almost 40,000 tests a year back in the time. But what is impressive is up to almost 12% of those being tested in the clinics tested positive for HIV, which is it's like an epidemic, like in Africa. Why? And this is what we're gonna look into. As in the United States, HIV is a pandemic concentrated in key populations or very most at-risk populations, especially MSM, men who have sex with other men. So among them, we have over 15% prevalence of HIV, but also among transgender women, where prevalence is very, very high. And women who come to get tested or who came to get tested to the clinic had also very high prevalence compared to general population, because these are women who are the couples of the men who are HIV positive. And among men, mostly MSM, we have different prevalences according to the group, the age group, but we have diagnosis among very young males, and I'll be back on this, but also among older men, and these men, they have lower CD4 cell counts. You're familiar with this terminology, right? And there's something that's important, and I want to focus on this. The fact that you need to have in the diagnosis service the possibility to refer your patients either to treatment if they test HIV positive, or to prevention services in the same clinic. This is very important. You have to be able to retain them. And not only test for HIV, but also test for other sexually transmitted diseases. So this is the continuum of care. You've heard of it, the continuum of care that comes from diagnosis to linkage to care, and then treatment, retention, adherence to that treatment, and in HIV, virologic suppression. This is true for most diseases, chronic diseases mainly, but in HIV, it is very, how do you say, failure to treatment is more easy if you abandon treatment anytime. And it's also important to have the same continuum of care among those who test HIV negative, because if you just let them go, they will come HIV positive, they will come back in 2 or 3 years with an HIV infection if you did not. And you also have to guarantee they adhere to whatever prevention strategy you establish for them, whether it's pre-exposure prophylaxis or other means of prevention. And just to give you an idea of how large the clinics, those 2 clinics right now, back in the time it was only one, about 15,000 HIV patients were taken care of by in these clinics. There were ID physicians, internal medicine physicians, and other specialists, but also general physicians, general medicine practitioners treating HIV patients as well. So the message here is, if you really want to have an effective HIV program, and I think this is true for most chronic diseases, you have to understand not the whole population, but not only the whole population or the population as a whole, but you have to go into the very specific characteristics each group has, so that you can implement specific targeted programs for each population. Otherwise, if you offer a general care and prevention program, some populations will be left behind, will not be attained. So first of all, you have to understand the epidemic, the prevalence, and everything else in each of these groups: transgender women, male sex workers, MSM. As I was saying, females who are partners of HIV positive men, inmates, prison inmates. There's another pandemic there, either among male or female inmates and drug users. And you also need to have a very specific program targeting HIV detection among pregnant women. So in the clinic, we developed a specific program, prevention and care program for each of these populations. And we'll talk a little bit about these. A program for male sex workers called Punto Seguro, which means safe spot. And we chose this name because it's safe not only from the healthcare perspective. These populations are always persecuted by police officers and by other authorities. And we want them to feel safe in the clinic. No one is going to persecute them or accuse them of them. Transgender women, a program for transgender women, a program for HIV positive women, and very specifically for female sex workers, for pregnant women, obviously for MFM, for prison inmates, as I was saying, for sexual violence victims, mainly a prevention program, for drug users, for serodiscordant couples, and for patients who are being diagnosed with an acute infection, which is a very important group. So I'm going to give you some data. I'll leave the dessert for last, the most interesting one, I think, especially today, the 6th of November, which has to do with immigrants. And so I'll leave that for last. But first, I want to talk about this program. It's a program we developed in 2009. Actually, that's when I joined the clinics. And I was very lucky with my tutor to implement this program, because we found a very difficult situation among prison inmates in Mexico City. Only around 30% of those who were in treatment were virologically suppressed. And we started doing HIV tests and STD tests in all the Mexico City prisons. At the moment, there were like almost 40,000 inmates was the population in the Mexico City prison system. Something happened. Maybe it's second. There you go. So we implemented this new model of care in the 4 prison inmates in Mexico City. What were the components of this new system or this new model? First of all, we brought specialized care to the prison, inside the prison, because before that, they had to go to, with all the police officers and everything, to the HIV clinic outside the prison, and that was very difficult. Sometimes they just weren't taken to the clinic. So we brought the clinic into the prison. That was first. Obviously, we did all the treatment switches and adequations needed for each person. We included mental health care for them, and pharmacy improvement, supervision, daily on a daily basis, and some educational sessions for them, for the inmates. And at the end, I don't know what's wrong. Looking at the timer. I don't know how I did that. Well, I'll use it. So what happened? Sorry, thank you very much. Thank you. What happened? That, as I was saying, around 30% of the inmates were biologically suppressed before this program started. And 2.5 years after that, or 2 years after that, about 80% of patients were biologically suppressed. And what's more important, I would say, is that before the new program was implemented, almost 10%, we had almost 10% mortality rate each year. And only 2 years later, rate went below 1%, as you are very familiar with. HIV is a treatable disease and should have zero mortality rate due to AIDS defining diseases. So what we think actually changed or improved adherence among prison inmates was, yes, taking care, as I was saying, inside the prison. Secondly, treating other complications and other diseases, not only, if you're not here for an HIV-related disease, you go somewhere else. You go to a different doctor, because I'm an HIV physician. You don't tell them that. You take care of whatever that their need is. And thirdly, you make them participate in helping other inmates become adherent to treatment. You do peer groups and peer. It was so shocking for me. There was this guy who distributed drugs in the prison. He sell the drugs, and he once came to the office and said, "What I do is I sell the drugs, but for me it was easy to tell them, you have to take your medication." Back in the time, it was efavirenz that was being used, and efavirenz is better to take it before going to bed in the nighttime. So I told everyone, you take this at 10 o'clock. You take it at 10 o'clock. So what he did was, at 10 o'clock, he said, everyone, I'm not selling any drug anymore unless you bring your pill in front of me and you take it. And so people were very adherent to treatment. So see, that was not my idea, I swear. How can go all the way to that kind of idea. And finally, you have to choose the correct treatment for each person. You have to adapt to the patient reactions to the treatment and the patient needs, so that he gets the right treatment for his personal needs. Well, this is prison. But then we started also a program focused on transgender men and women. Not only women who are those who have a high HIV prevalence, male transgender populations has very, very low HIV rates, but still the clinic, the transgender clinic in the HIV clinic was for both populations. And the transgender clinic was focused on hormone therapy, which is their main interest. They really, in Mexico, it is very expensive to get the hormone therapy. So the clinic, HIV clinic, offered free hormone therapy with endocrinologists, with psychiatrists, helping them to get the treatment they really wanted. And we used that clinic to get them tested for HIV and other diseases and offer treatment for whatever the disease was, HIV or otherwise. So this has been a very successful strategy. Here are the prevalences. As I was saying, among transgender women, HIV prevalent, well, this is age distribution, and the percentage of men and transgender men and transgender women, and here it is. And this is the HIV prevalence, over 20% among transgender women and 0% among transgender men. But we have to understand the situation they're living. They're going through a lot of stigma, discrimination, violence, and they end up being in a very vulnerable situation such as poverty and living in homelessness and having to go to work in sex work because no one else gives them a good job. And we found, this was a WHO funded research, that health issues were higher, the prevalence, suicidal ideas and all of that were much higher among transgender women and men. But we found that it was not related to or due to their transgender identity, but it was due to the violence they suffered because of their identity. And so it was about offering a complexive care for these populations, not only the HIV testing and treatment or the sexually transmitted diseases treatment, but also, as I said, hormone replacement therapy and mental health care and prevention strategies for them. And then we have this program for sexual violence victims. And we worked together with the what we call the prosecutors in Mexico, because we taught them to bring them to the clinic very quickly, because the intervention time for post-exposure prophylaxis the window is very narrow. And the faster you act, the more effective the strategy is. And so imagine, in those 10 years, almost 10,000 victims were taken to the clinic. And you have to take into account that most victims do not go to the police, do not talk about it. So this is hiding real numbers, which are more, which are bigger than what you see here in the screen. And we saw pregnancies due to the sexual violence, and we were not always able to offer post-exposure prophylaxis. Only 1/3 actually benefited from that. We also have what as I was saying, the Safe Spot program for male sex workers. This is very important because these men do not go to clinics unless they really are in an emergency situation. They don't seek medical care regularly. And you have to go find to the streets. You have to go, and they kind of hide. It's not evident. So we had an anthropologist helping us to talk to them and to convince them of trusting the clinic and coming to the clinic. So we had to send like a van to look for them, and you have to gain their trust and then bring them to the clinic and offer not only the testing, which look at the HIV prevalence. 38% already had HIV and no one was on treatment. And they were having sex work. It was harmful for themselves, but also for their clients and their clients' families. So, but it's important, and it's important for them that you take care not only of their HIV or STD disease, they have no medical care at all. And if they have an accident or, a fracture or whatever, they trust you and no one else. So you have to take care also of those other diseases, even if you're an HIV clinic. At least refer them and accompany them so that they get good care. Or they will not trust you anymore. There was also a program, I will not talk much about this, a program for drug users, IV drug users and other drug users. This is also very important. We do not have a very big epidemic among drug users, specifically in Mexico as in other places or in other countries like Asia or Eastern Europe. But still, we do have some HIV cases related to IV drug use, mainly in the northern border of the country. But now we're talking about Mexico City, so I'll stop there. You also have to have program focused on homeless or people in situations homelessness. And you, as MSM male workers, sex workers, they will not come by themselves to the clinic. You have to go and have outreach programs to bring them to the clinic. Adolescents. Adolescents is a very, I'm sorry, I'm almost out of time, but adolescents is a very sensitive population, and you need very teams that are very sensitive to their realities, and you will find very the characteristics among adolescents are very, very specific. I will not talk much about it. Sorry, because if I don't jump to the immigration slides, I might miss that. And you also have to have ways of finding who is going through an acute infection, because HIV acute infection is not always easy to diagnose because they don't have antibodies. So you need very specific tests, but mainly because they have very high viral loads and they have a lot of sex partners at the moment. So if you don't treat them right the same day when you diagnose them, you will have new infections next day. Sorry, I have to jump to this. What we call the Clínica Santuario. Maybe you remember back in the time the concept of sanctuary cities here in the United States. So we took the idea from you, and we said we want the clinic to be a sanctuary clinic where they can come and no documents will be asked for them in exchange, as a requirement for treatment. Whoever comes from whatever nationality or whatever status, they will be taken care of in the clinic based on human rights laws in Mexico. Authorities weren't very happy about this because they were people who didn't have insurance at all, but we still gave them treatment. And it's important to understand that among migrants, many do know their diagnosis and they come to the clinic looking for continuation of their treatment, but they need to know they can trust the clinic and they will not be sent to the authorities because most of them do not have documents. I'm sorry, I'm running out of time. I'll rush. You have to understand the very particular characteristics of each group. We found that for example, among Central Americans, there were men and women and transgender women living with HIV coming to Mexico City, but they have very few support networks, and networks are important for adherence and for treatment success. But when it comes to South Americans like Argentina and others, they have higher status and they have support networks. We have a lot of people coming from Venezuela, some people coming from Africa, also from Europe and North America, and Mexicans, and I think we will have a lot of this, sadly, in the coming years. Mexicans who are being repatriated from the United States to Mexico, who were born here or who have been here since their childhood, but who are being repatriated to Mexico. Yes, they have families, but sometimes they don't even speak Spanish. Yes, they used to have treatment here, but they don't know where to go to or where to take care of. So they're going through a cultural shock when they come back to Mexico. As I was saying, they sometimes don't have the networks, and because they didn't have the documents, they are being sent back to Mexico. So the program was taking care of them too. So this is in Mexico back in the time. Those who have a cross, an X, are those who do not have the right for treatment, and according to bureaucracy, and who need treatment. And I think this is it. So this is the basis for the program, human rights. And yes, I will stop here, I think. This is more text. Okay, I'll stop here because it's more about the migrants and the sanctuary clinic program. So thank you very much.